Thank you, Joe, and thank you for a great introduction to non-invasive technology and a little bit of the history. And now that we've had a look at NIPT in more depth, we're now going to consider NIPD, that's non-invasive prenatal diagnosis. And what I'm going to do is first give a recap, so having a look at why we might perform NIPD, and then have a look at some of the benefits and challenges that this test might bring. And then I'm going to talk you through a case study that illustrates the difference that NIPD has the potential to make for families, and highlight some of the challenges this brings for us in midwifery. And then at the end, we're going to direct you to some further resources. So essentially, what we're doing with NIPD is using the same principles. We're using the same technology in that we are taking a sample of maternal blood and analysing some of the placental DNA. And we might use this, for example, where there is a pregnancy at risk of inheriting a monogenic condition, or we might use it for rhesus D genotyping to prevent hemolytic disease of the newborn, or we might use it to determine fetal sex where there is a risk of an X-linked condition in the fetus. So let's have a look at the benefits. So first of all, it's safer. It's safer than invasive testing that we currently have because we're only using a maternal blood sample. And of course, those of you who work in fetal medicine and screening will be aware of the anxiety that that risk of miscarriage with invasive diagnostic testing creates for women. Secondly, it's early, so we can perform NIPD as early as 8 or 9 weeks of pregnancy. And in fact, in some cases, we can get the results back before the point at which CVS would even have been available. But of course, we can only take advantage of this early detection if we get women into care early enough. So there's a challenge here for us in midwifery in terms of getting women seen and referred early. And finally, it's accurate in terms of the fact this is a diagnostic test, it's not a screening test. And so in many cases, we don't need to take confirmatory invasive testing. So, of course, we also have challenges with this technology. First of all, the scope of NIPD is limited. We can only offer it for a specific limited list of genetic conditions. And if you want to know which conditions are currently available, then head along to the National Genomic Test Directory, and you'll be able to see in there where we can offer NIPD and the inclusion criteria for offering those tests. There are exclusion criteria, so it's not available to everyone. So, for example, in multiple pregnancies, or if you've got a vanished twin pregnancy, or if the mother has had an organ transplant, then we wouldn't be able to offer NIPD. And now you'll also see on this slide that I've included close relative couples or close relative relationship or marriage. And at the moment, you can't offer NIPD for couples who are in a close relative relationship. However, we know that that's going to change imminently. We've heard that it's going to be included in the next version of the Genomic Test Directory. So that's a really important step forward in the story of NIPD because we will be able to offer it to an increasing number of people. There are also issues in some cases where we need to undertake a pre-NIPD workup. So we need to do additional tests before we get to the point of offering NIPD. Now, in an ideal world, we would offer these tests preconceptually just to speed things up so we can offer NIPD as soon as possible in the pregnancy. But of course, if someone comes to us with an unplanned pregnancy or presents very late in pregnancy, then that might delay the point at which we can offer NIPD. There are also specific requirements on the type of samples that we require in some cases. So in some cases, we need samples from both biological parents, so from the baby's father as well as the mother, and also sometimes from a previous child, whether affected or unaffected. Now, if the couple haven't had a previous child or we haven't got access to perhaps the father or another child, then we might not be able to offer NIPD. And finally, like any test, there's always a small chance that there may be an inconclusive result or the sample may fail, for example, for technical reasons. So we're now going to come on to our case study, and our case study involves a condition called retinoblastoma. So before we talk about our family in more detail, we're just going to give you some background information on retinoblastoma because it might be something that not many people are aware of. So you may have heard of this condition. Sometimes you hear about it in the news where perhaps someone in the family has taken a picture of a newborn baby and they perhaps post it on social media, and someone notices that there's a glow or a disc, a white disc in one of the eyes. And in fact, if you can probably just see on the baby in this slide here, the baby's left eye has got a sort of paler disc in the center, and that could be indicative of retinoblastoma. So what is it? Well, basically it's a form of eye cancer, and it affects about 1 in 15,000 to 1 in 20,000 live births every year in the UK. It's caused by variants in the RB1 gene. The RB1 gene is located on chromosome 13. And RB1 as a gene provides instructions for making a protein that acts as a tumor suppressor. So where you get variation within that gene or changes within that gene, that can inhibit the action for making that protein, and therefore that can result in excessive cell growth and hence cancer. There is good news, though, in that it is a very treatable condition, and the cure rate can be as high as 99% if we identify it early enough and if it's confined to the eye. In England, we have a national retinoblastoma service, and treatment is coordinated out of 2 centres. So we have one centre in Birmingham and one centre in London. So in terms of inheritance, about 45% of cases are inherited, and it's inherited via an autosomal dominant inheritance pattern. And where it is an inherited form of retinoblastoma, then it's often bilateral, so we often see tumours in both eyes. Genetic testing is available, and we can offer it where retinoblastoma has been diagnosed perhaps in a child or baby, and also where there's a family history of the condition. If we find that a child is found to have a variant, we can then offer enhanced surveillance so that tumours can be caught early and then treated immediately. And of course, that improves the outlook for those children. So in terms of NIPD, it's now available in some cases for a singleton pregnancy where a mother, a father, or previous child has been diagnosed with the condition. It was first available in 2016. Initially, it was just available for paternally inherited cases only. But in 2022, it was included in the National Genomic Test Directory and can now be performed for paternal, maternal, and also likely de novo cases. We process the samples at 2 labs at Birmingham and London, and Birmingham have performed a series of 23 tests to date, and so far all those results are concordant. So that means that the results of the NIPD matched the situation in the baby when checked after birth. So onto our case study. Our case study involves Jane and Adam. Adam has a heritable form of retinoblastoma that was diagnosed and treated when he was a baby. And they decided as a couple that they wanted children, but they wanted to avoid having a baby with the same condition that Adam has. So they have a child called Ben, and Ben was conceived using pre-implantation genetic diagnosis. And that's a process where a couple goes through IVF and the embryos are tested to see if they've inherited the genetic variant from the father in this case, and then only healthy embryos are re-implanted into the womb, and that resulted in Ben. So the couple were very happy, didn't want any other children at that. They were very clear that they would never consider termination for any reason, and therefore they wouldn't have had prenatal diagnosis because they wouldn't have wanted to risk miscarriage. So they were very sure in that. And having had one healthy child, they decided that's it, we're not going to have any more children. They didn't want to take on that risk of retinoblastoma. So that's fine until Jane, at age 42, finds out suddenly that she's 9 weeks pregnant in an unplanned pregnancy. Jane then goes along to that first midwife appointment, which we call the booking appointment. And the midwife there takes a medical, social, and family history. And she notes at that point there's a history of retinoblastoma, and the midwife correctly recognizes that this is a genomic red flag, and that as a genetic condition, then she offers referral to genetic counselling and fetal medicine to Jane. However, Jane declines that, and she declines it because she says that, well, I had counselling before and during my last pregnancy. I wouldn't want invasive testing. I understand the risk. We wouldn't terminate for the condition, and that she's already had a long conversation with Adam, and they decided that they could cope if their baby had retinoblastoma. So they're just going to continue the pregnancy as is. Now, of course, she's basing these decisions on information that she gained during past encounters with clinical genetics. And at this point, neither Jane or the booking midwife are aware that NIPD is now available for retinoblastoma. In fact, Jane at age 42 is far more concerned about the fact that that carries an increased chance of Down syndrome. And that's sort of consuming her, and sort of takes over part of the booking, really. She then opts to have combined screening. And because of her anxieties about Down syndrome, she is referred for a conversation with the screening midwife to discuss her combined screening results. She gets a low chance of Downs on that combined screening test, so she's reassured about that, doesn't want any more tests. But at that point, the screening midwife notes the history of retinoblastoma and thinks that NIPD might be an option. So the screening midwife does the right thing. She contacts her local genetics department and explains the history. And the genetic counsellor said, yes, we should probably see this couple because NIPD probably would be an option. So the screening midwife contacts Jane and explains what NIPD is. Would they like to talk about it in more detail? So they go along to the genetics team, and after a detailed sort of family history and discussion, the genetics team say, yes, we can do a bespoke form of NIPD. We have to do a pre-test workup, so it's going to take a little while. So they go through that, they proceed with NIPD, and then at 20 weeks, the results come in, and it's good news. The baby hasn't inherited the variant that Adam had, and will not develop retinoblastoma. So this is great news for the family, of course, and it's means that they don't have to worry about it through the second half of their pregnancy. They can look forward to their baby and know that retinoblastoma isn't going to be a problem. However, if it had have been positive, then the couple would have had time to prepare for having a baby with this variant. And then they, of course, we could have implemented a detailed antenatal and postnatal management plan to prepare in advance of the birth. So again, we want to give you some key takeaways from this case study, because on the face of it, it sounds fine, right? This woman comes along, it was picked up that NIPD could be offered. She had NIPD, and of course, it was a good result. However, there are a few things just to highlight, and I've already mentioned that NIPD is available from 8 weeks of pregnancy, and that we can often do NIPD and get a result back before invasive testing is possible. Now, in our case, if she had have been referred at booking, then we could have brought forward the results by a few weeks. And it might not sound that's a big deal, but believe me, it is a huge deal for parents who are at risk of having a baby with a genetic condition, where every week or every day not knowing just creates more anxiety. So early booking and early referral is essential. Also, delaying NIPD may reduce options for people. Now, again, in our case study, Jane was clear she would never have a termination for any reason, but some couples might have a termination, might consider it as an option. And if we delay NIPD, then it may reduce the options for those couples who may consider termination. There are rapid developments in genomics, and things are changing all the time, and sometimes it feels like it's changing on an almost daily basis. Jane thought that she knew all her options, but this was based on her past experience and past discussions, and things have changed significantly since she had her first child. And in reality, in our case study, it was only luck that the screening midwife identified that NIPD might be an option. So what we would say is, where there's a history of genetic or genomic condition, it's always worth checking out what's new in each pregnancy, and or ideally before someone conceives, because testing and treatment options may have changed since previous experience with genetics and genetic counselling. Midwives don't need to know and indeed can't know everything about genomics. And I think it's fair to say that neither Joe or I are experts in retinoblastoma, but it doesn't matter. What you need is an understanding of the fundamentals. And if you understand the fundamentals of genomics, it can help you identify and act on those genomic red flags that we might identify in preconceptually or at booking or at any stage in the pregnancy. And so having that genomic knowledge can empower midwives to support and empower parents to make informed personal choices about their care. We wanted just to give a couple of pointers about the future and what the future might look like for NIPD. And the first one, really, I've already touched upon, and that is the expansion. And in terms of what I'm talking about here really is the range of conditions for which NIPD is available for, and the circumstances where we can offer NIPD is likely to expand in the future going forwards. And I've already mentioned, of course, that any minute now we will be able to offer NIPD in England for couples in a consanguineous or close relative relationship, and that's a huge step forward. We're likely to see NIPD being available for more conditions in the future as well. Again, but they has to go through research and then has to be agreed by NHS England or Department of Health going forward. Secondly, I just wanted to mention research in terms of the generation study. So the generation study is probably one of the biggest or most important research program in genomics in England since the 100,000 Genome Project. And what we're aiming to do is undertake whole genome sequencing on 100,000 newborn babies to try and identify some of those 9 babies born every day in the UK with rare genetic disease, where we can offer a treatment and make a difference. Now, we're going to be looking for over 200 different conditions on the generation study. And one of the conditions we're looking for is retinoblastoma. So we are going to be looking for variants in the RB1 gene. And this is important because I said that 45% of cases of retinoblastoma are inherited. So there are many cases that are de novo or new. And this might be a way to identify babies with those forms of retinoblastoma where there's no family history, early, as soon after birth. And we will come back later in the year, I think, and talk in more detail about the generation study because it's such an important research program in genomics. So this slide is just giving you some information about where to go if you want to find out more. First of all, about retinoblastoma. So we have a Childhood Eye Cancer Trust, which is a support group for the condition in the UK, and there's some information there on the NHS website. And then if you want to know more about non-invasive prenatal diagnosis, then again, you can go on to GeneNotes and have a look about more information about that test. I'm going to talk more about GeneNotes on a slide in a couple of minutes as well. Today, we don't have time to go into the intricacies of NIPD and the different types of NIPD. It is quite complicated, certainly from the lab perspective. And as Joe said, neither of us are scientists. But there is a really good video on YouTube of a webinar that we recorded a couple of months ago. And one of our laboratory scientists from Birmingham is talking in detail about NIPD. So if you want to know more about it, then go and have a look at that video. It's only an hour long. It's available on YouTube. And we've also got another case study there, which just gives you a further example of where we might use NIPD. And then the last resource on there is a paper from the team at Birmingham, just detailing the series of NIPD for retinoblastoma that they performed in their lab. So we're just on to the final few slides now. So we wanted to give you something to take away, some resources, and we call this our sort of genomic toolkit, really, to support you, to support parents, to empower midwives and empower parents going forward. And I think the word genomics for midwives can be a bit scary, but I say that midwives are already genomics practitioners. It's just that they don't always realize it. And certainly we already have, as midwives, we have advanced history taking skills. And what we want to encourage you to do is to be more genomic curious at booking to help you to identify those genomic red flags. How can you do this? Well, upskilling and learning more is a really good place to start. We've got the NHS England Genomics Education Programme. There's lots of free resources on that website that you can access. Now, sometimes it can be really confusing to know where to start with these resources. So a new initiative that we've developed is the Genomics Learning Passport for Midwives. And this is basically, it's a guide to all those key genomic learning resources, starting at the very basics, starting at what is a gene, what is a chromosome, what is genomics, and then increasing in levels of complexity. It's a Word document, so you can download it from the Genomics Education Programme website and then just work through the resources according to your sort of sphere of practice or however much you want to do. And hopefully that will help you navigate your way around the resources that are out there. There are also some other good resources available. The National Genomic Test Directory, we've both mentioned that. We've just put the link there. Our colleague Denise Barnes, who's lead midwife in northeastern Yorkshire, developed a great little prompt card on genomic red flags. And these are cards which highlight the kinds of questions that you should be asking at booking and highlight where perhaps to probe further to find out more about somebody's history. Also gives you details of how to refer on, who to refer to, and these are available to download free from the Northeastern Yorkshire website. And then we've just put the link to GNotes, which both Joe and I mentioned. So GNotes stands for genomic notes, literally, and there's lots of information on there. You can just type in a condition, or perhaps if you found something on scan like short long bones or fetal ovarian cyst, you can kind of type it in and it will give you information about whether that's a genomic condition, what kind of testing you should be offering, and perhaps where you might need to refer on. So great, concise, good quality information available at your fingertips. And then finally, it's important that you know who to go to access further information or advice. And we strongly recommend that you know who your local genetic counselling service is, because I think it's fair to say they would always rather hear about a case sooner rather than later. All genetic counselling services have a prenatal team, and they encourage midwives to contact them, but the method of contacting them may be different according to where the service is. So if you're not sure who your local genetic referral services in your area, this is in England, then you can go on this website. There is an interactive map and you can find out who your local service is. And sometimes it might just be a case of finding out who is interested or expert in genomics in your trust, whether it might be a screening midwife or fetal medicine midwife or consultant, where you might just need to pick up the phone and ask for advice. It's also important to stay up to date with the latest genomic advances, and there are lots of ways to do this, but there's lots of newsletters and networks out there. All of the GMSAs, as far as I'm aware, have a newsletter that you can sign up to. The Genomics unit at NHS England have a newsletter, as does the Genomic Education Programme. That's a great way of just finding out what the latest developments are. We also have National MIGSnet. So MIGS stands for Midwives in Genetics and Genomics Network, and we meet regularly every month. We invite people to come and listen in, either as observers, or we're also looking for new members. So if you're working in England and particularly interested in genomics on the maternity pathways, then drop us an email. Well, at the moment, actually, we're looking for anyone who's got a particular interest in neonatal care. So drop us an email and we will invite you along if we've got space to do so. And then finally, last but not least, there are many local and national support groups out there which can help you to support women, people and families in your care, and also help you with information and support and advice as well. And we can't list them all, there are many, but the Genetic Alliance UK is a really good place to start, and that includes a directory of organisations across England where you can find out whatever condition is, find out what support groups are available. So I think that's my last slide. Thank you everyone for listening.